My name is Dr. Clair Francomano, and I'm a medical geneticist, and I'm very, very pleased to be here with you today to talk about Ehlers Danlos syndrome. My title is Ehlers Danlos syndrome and lipedema. I'm going to really talk about Ehlers Danlos syndrome and a few thoughts at the very end about how lipedema may be connected to Ehlers Danlos syndrome. So in 2017, there were a series of papers that were published defining a new classification of Ehlers Danlos syndromes. The Ehlers Danlos syndromes are a very widely diverse group, similar in the way that the fat disorders are a diverse group of diagnostic categories. The Ehlers Danlos syndromes also are widely diverse. There are now 14 different types that are recognized, and we know the genes that cause 13 of those. The most common form is the hypermobile type, and we do not yet know the genes that cause the hypermobile type of Ehlers Danlos syndrome. So this classification has now been published. It's in the American College of Medical Genetics, and it's also available on the Ehlers Danlos Society website, which is ehlers-danlos.com. The classical type of Ehlers Danlos syndrome was the very first one to be described, both by Dr. Ehlers and Dr. Danlos back in the 1800s. And the major criteria for this condition are joint hypermobility, which is the underpinning really for all of the Ehlers Danlos syndromes, is the joint hypermobility. But in the classical type of Ehlers Danlos syndrome, the skin involvement is really the hallmark. These are the people who have the tremendously stretchy skin. They can take their skin and just really pull it out to here. There are a number of minor criteria that have also been described. These include easy bruising, which is another thing that we see in many of the different types of Ehlers Danlos syndrome. The skin can be soft. It's sometimes described as doughy. It has very, very extensive fragility. So these are children when they walk into a coffee table, when they're starting to toddle around, they get traumatic wounds in their legs because the skin just splits. There are soft tissue tumors under the skin, what we call them molluscoid pseudotumors, and subcutaneous spherules that feel a little bit more like sand under the skin. And there may be hernias or a history of hernia. Some people with the classic type of Ehlers Danlos syndrome have epicanthal folds, and they have complications of joint hypermobility, which include subluxations, dislocations, sprains, etc., and a lot of musculoskeletal pain. And then there may also be a family history or first-degree relative who meets the diagnostic criteria. And in order to make a diagnosis, a clinical diagnosis of the classical type of Ehlers Danlos syndrome, we require that very, very stretchy skin. That's the first thing. And then either the joint hypermobility or 3 of the 8 minor criteria. Now, just to give you some illustrations what we're talking about here. So the skin hyperextensibility is, as I mentioned, really can be quite dramatic. And the scarring can be very dramatic. So these knees illustrate the molluscoid pseudotumors that we can see. You can see that the scarring on this woman's face is quite dramatic. And wound healing often is not optimal. So people will get sutures. The sutures will be removed. The wounds may dehisce or open up again, requiring additional suturing. Now, in order to define joint hypermobility, and this is true for all of the different types of Ehlers Danlos syndrome, we use something called the Beighton scale. And just to back up a little bit, those papers that were published in 2017 came about as a result of an international consortium that met over the year between 2015 and 2016, and then the group met in New York in 2016 to present their findings. And one of the committees that was involved in that 2016 consortium meeting was a group that was assigned to say, how really should we be defining joint hypermobility? Because we've been using the Beighton score for years, and we recognize that it has very significant limitations. I'll discuss those limitations in a minute, but let me describe this score to you first. This is a 9-point scale, and you get 1 point for each item that you're able to complete upon examination. So the first thing is, are you able to put your palms on the floor without bending your knees? That gives you 1 point. Now, if you're able to touch your thumb to the wrist here, like this, I can't do it, but that gives you 1 point on each side. And if you're able to go more than 90 degrees, so if you put your hand on the table and you're able to bend your 5th finger back more than 90 degrees on each side, that gives you 1 point. Then we look at the elbows, and we measure the angle between the upper part of the arm and the lower part of the arm. And if there is more than a 10-degree angle extension beyond straight, we call that a positive, and you get 1 point for each of those. And then if the knees hyperextend, and you can see on this illustration in the upper right-hand corner, if they extend more than 10 degrees beyond 180, we get 1 point for each of them. Now, one of the innovations that this group in 2016 made was they made different cutoffs for different ages, because we recognize that there definitely are differences in flexibility in the average population as people age, right? Kids, just in general, are going to be much more flexible than their grandparents, for example. So the cutoff for defining joint hypermobility in children, if they're pre-pubertal, is 6 or greater. And if people are in between puberty and the age of 50, we use a cutoff of 5. And if people are older than 50, we use a cutoff of 4 to define generalized joint hypermobility. Now, Dr. Rodney Graham and Dr. Alan Hakim in London also did some studies looking at a very simple 5-point questionnaire. And they found that if they asked people 5 questions and people gave affirmative answers to 3 of those questions, it correlated very well with joint hypermobility based on the Beighton score. And I have those 5 questions here. I'll read them to you now. It's, can you now or could you ever place your hands flat on the floor, so that 1 point in the Beighton score. Can you now or could you ever bend your thumbs to your wrist? As a child, did you amuse your friends by contorting your body into strange shapes, or could you do the splits? As a child or a teenager, did your shoulder or your kneecap dislocate on more than one occasion? And then the 5th question was, do you consider yourself to be double jointed? So that's the 5-point questionnaire, and in the rheumatology literature, it is published that if you have 3 or more affirmative answers to those 5 questions, then we can call it generalized joint hypermobility. What the committee did in 2016 and what's published in the 2017 papers is to say, if you have 2 or more questions affirmative on that and you're 1 point shy on the Beighton, you can get a bonus point for your Beighton score, basically, and bring the Beighton score up to be considered as generalized joint hypermobility. Dr. Hakim and Dr. Graham aren't really so sure that that's an appropriate use for this questionnaire, but anyway, that's what's published, that's what's in the literature right now, and that's how we're using it. So, to establish generalized joint hypermobility, you need the age-specific cutoff for the Beighton score, and you may or may not get 1 extra point with the questions from the 5-point questionnaire. And for classical Ehlers-Danlos syndrome now, we have molecular confirmation because we know that 95% of cases of classical Ehlers-Danlos syndrome are caused by mutations in one of the 2 genes that encode type 5 collagen. So these are COL5A1 and COL5A2, and if we can find a pathogenic variant, in other words, a disease-causing mutation in one of these 2 genes, then we've confirmed our diagnosis of classical EDS. Now, for vascular Ehlers-Danlos syndrome, the committee gave us major and minor criteria, which are listed here on this slide. I'm not going to go through them in detail because the committee did not use these major and minor criteria to actually recommend a clinical diagnosis. They gave us minimal criteria suggestive of vascular Ehlers-Danlos syndrome. And really the hallmark for vascular Ehlers-Danlos syndrome is the fragility of the blood vessels and the tendency for people to develop vascular rupture, so arterial ruptures and dissections. And for that reason, this can be a life-threatening disorder. And if you think of it, it's very important to make the diagnosis. So the committee for the vascular type suggested that if there is a family history of this disorder, if there has been an arterial rupture or dissection in persons less than 40 years of age, if there's been an unexplained rupture of the sigmoid colon or spontaneous pneumothorax, we should think of vascular Ehlers-Danlos syndrome. And if you think of vascular Ehlers-Danlos syndrome as a possible diagnostic consideration, it's very important to do the molecular testing and look for the pathogenic variants in COL3A1, which is the gene that underlies type 3 collagen. And type 3 collagen is the protein that's abnormal in the vascular type of EDS. Now, probably the biggest change that came out of these considerations and when this international consortium met in New York in 2016 was the development of a new set of criteria for the hypermobile type of Ehlers-Danlos syndrome. And as I mentioned, this is the most common type, and really having a good set of clinical criteria is extremely important because we do not have a molecular test to confirm the diagnosis. So this was an arduous process, to say the least. There was a lot of very vibrant discussion that went on in leading up to this decision, and the committee came up with a set of 3 criteria, and according to what we're using now, the criteria we're using now, you need to meet these 3 criteria in order to establish a diagnosis of hypermobile EDS. You need generalized joint hypermobility. That's criteria 1. Criteria 2, you have to have 2 out of 3 options. 1 is a positive systemic score of at least 5 out of 12 systemic findings. 2 is a positive family history. And 3 is the musculoskeletal complications. And then for criteria 3, you just want to make sure that you've really done your homework and you've made sure that this isn't being caused by anything else. So we want to make sure it's not the classical type of EDS. In other words, we don't have that unusual skin fragility that you see in classical EDS. We want to make sure we've excluded all the other hereditary and acquired connective tissue disorders and any other alternative diagnoses that may also cause joint hypermobility. And there is a diagnostic checklist. It's a 1-sheet diagnostic checklist, and that's available at the Ehlers Danlos Society. And I'm just going to those 12 criteria, because I know you can't see it from there, and I certainly can't see it from here. I'll tell you what the 12 are that establish kind of the systemic score. One is the unusually soft or velvety skin. These people have mild skin hyperextensibility. They don't have the tremendously stretchy skin that we see in the classical type, but they do have more stretchy skin than the average population. They may have unexplained stretch marks, which are not caused by obesity, not caused by pregnancy. There's something called piezogenic papules, which are little bumps that appear on the heels when you stand on your feet, and they little nodules that poke out. Bilateral piezogenic papules on the heels are one of the criteria. Recurrent or multiple abdominal hernias, the atrophic scarring, which I showed you a picture before, pelvic floor, rectal or uterine prolapse, dental crowding and a high narrow palate, very long thin fingers, long arms relative to the height, mitral valve prolapse, and aortic root dilatation. So those are the 12, and if there are 5 or more of those, that meets that systemic diagnostic criteria. So the committee recognized that there are going to be people who have joint hypermobility who don't fit into this more rigid diagnostic rubric that they established in 2016. And we needed to have a way of acknowledging that these are folks who have musculoskeletal issues, and they may even have many of the same comorbidities that we see in the hypermobile type of Ehlers Danlos syndrome. And so Marco Castori from Italy and this committee that was looking at the hypermobile type came up with a new classification of hypermobility spectrum disorders that include people with asymptomatic joint hypermobility, people with a well-defined syndrome of joint hypermobility, or people who have symptomatic joint hypermobility but don't meet the diagnostic criteria for a specific syndrome. So in defining this spectrum of joint hypermobility, they said, well, look, how can people have joint hypermobility? They may have localized hypermobility in just one joint. It may not be generalized. They may have a shoulder that just comes out all the time. It may be peripheral joint hypermobility. In other words, just the small joints of the hands and the feet, which is the type of hypermobility that we actually see in the vascular type of Ehlers Danlos syndrome. There may be historical hypermobility. People may say to you, when I was a kid or in my teens, I could do all those things on that 5-point questionnaire, but now I'm 50 and I can't do any of it anymore. So in thinking about localized, peripheral, and historical joint hypermobility, it may be just those things, hypermobility. If it's associated with symptoms, we call it a hypermobility spectrum disorder, localized, peripheral, or historical. And then at the far end of the spectrum, if people meet the diagnostic criteria for the hypermobile type of Ehlers Danlos syndrome, that is the extreme end of these hypermobility spectrum disorders. Now, as I mentioned, there are quite a few comorbidities that are associated with these various types of Ehlers Danlos syndrome, and really we know the most about them in relation to the hypermobile type of Ehlers Danlos syndrome, but we do see them in the other types as well. And Heidi Collins, who was the chair of the Professional Advisory Board for many years for the Ehlers Danlos Society, coined this phrase, if you can't connect the issues, think connective tissues. So we see issues in virtually every organ system in the body, starting with the heart and vascular system. There's evidence of orthostatic intolerance. In other words, when people go from lying down to sitting up, they develop wooziness or dizziness, they develop POTS, and neurally mediated hypotension. Their blood pressure may drop. Mitral valve prolapse is seen. Aortic root dilatation can be seen. This is different from the aortic root dilatation that we see in a condition like Marfan syndrome, because we don't really worry about aortic root dilatation in the context of the hypermobile type of Ehlers Danlos syndrome. It may be, the aorta may be a little large, but it doesn't get big to cause trouble, doesn't usually dissect or cause any damage. Venous insufficiency can be an issue in Ehlers Danlos syndrome, and maybe that is one connection with the fat-related disorders. We recommend for an evaluation, people have an echocardiogram, consider Holter monitoring if the palpitations are frequent or troubling. Sometimes a tilt table test can be helpful to define the orthostatic intolerance, and we do magnetic resonance venography to look for venous insufficiency. There are multiple neurologic complications involving the head, the spine, and the peripheral nervous system, and these include headaches. Dr. Fraser Henderson gives a lecture about headaches in Ehlers Danlos syndrome. We have 13 different types of headaches that you can get in EDS. There is something called cervical medullary syndrome, which can be caused by Chiari malformation. People have neuropathic pain, occult tethered cord, and cerebral venous insufficiency, as well as problems with the autonomic nervous system. I'll tell you a little bit more about some of these specific things. So the cervical medullary syndrome is characterized by a headache, which is related to suboccipital pain in the back of the head here, or neck pain. Patients with cervical medullary syndrome may have myelopathy, so they have weakness, clumsiness, changes in their gait. They may have a spastic appearance to their neurology with altered sensation and pins and needles, and there may be problems with urination as well. These bulbar symptoms are symptoms that are caused by problems with the cranial nerves, so people have problems with their vision, decreased hearing, problems with balance, the autonomic nervous system. They may have difficulty speaking or difficulty swallowing, syncope, fainting, or feeling like they're going to faint, problems with their sleep. Another very interesting overlap to what Dr. Herbst was just talking about, and problems with sleep apnea. In the gastrointestinal system, we have problems with the stomach, problems with the gallbladder, the pancreas, and the colon. Some of the symptoms that we see are gastroesophageal reflux, irritable bowel syndrome. People complain of bloating and abdominal pain, which may be related to mast cell activation, another very interesting overlap with what Dr. Herbst just presented. Diarrhea and constipation. Stool incontinence may be caused by problems with the nerves in the lower back, food intolerance, and hernias. And in the genitourinary system, we see problems with the bladder, the pelvic organs, and the kidneys. The pelvic floor is supported by connective tissue. So if the connective tissue is not strong, the pelvic organs can kind of prolapse, they can fall down, they're not held in place, and they don't stay in the proper relation to each other. So that can be a major problem, and the symptoms that can result include urinary urgency, urinary frequency, difficulty starting urination, difficulty emptying the bladder completely. There may be urinary dribbling or incontinence, and frequent urinary tract infections. So we want to check for tenderness, look for evidence of inflammation, and we do a test called urodynamic testing to look for something we call a neurogenic bladder. Are the nerves that go to the bladder being pinched off? And we can also get evidence about that by doing something called pudendal nerve conduction testing. Now, in the allergy, immunology, hematology arena, We may have a history of hives or rashes, flushing, itching, frequent infections, severe allergies, autoimmune disorders, and a history of blood clots. Mast cell activation is a frequent comorbidity in these patients. And I think this may be another area of connection between the connective tissue disorders and the disorders of fat metabolism. I would say the musculoskeletal system is one of the real hallmarks of the hypermobile Ehlers Danlos syndrome phenotype, and people have muscle pain and spasm as one of the major and most challenging aspects of that. The muscles are literally trying to hold the body together because the tendons and ligaments are not doing their job in supporting the joints. Now, I would just like to add that fat is another feature, another tissue, another issue in which we see problems in some patients with hypermobile Ehlers Danlos syndrome. I have more than a handful of patients with comorbidities of either Ehlers Danlos syndrome and Dercum, Ehlers Danlos syndrome and lipedema, and Ehlers Danlos syndrome and lymphedema. And I think understanding how the connective tissue interacts with the fat and with fat metabolism, what the biochemical mechanisms, the biomechanical mechanisms may be that connect these two sets of disorders is really one of our big challenges. And Dr. Herbst and I were talking earlier in the week. I think there's a lot that we can do together to try to understand these comorbidities, and I really look forward to trying to figure that out with her. This is a quote from James Oshman, who said that the fascia forms the largest system in the body, as it is the system that touches all the other systems. And that fascia is made of connective tissue. So if your connective tissue is abnormal, your fascia is going to be abnormal. And I think that may be one link that connects connective tissue and fat. So we always say it takes a village to manage patients with multiple complex morbidities. And so particularly for patients with severe and unusual manifestations in multiple organ systems, we need multidisciplinary evaluation and management. And I thank you very much for your attention. Thanks to the Ehlers Danlos Society, the FDRS, Dr. Herbst, and all my patients. Thank you.
We have time for a couple questions. Thank you, Dr. Francomano. So a couple questions that we have. What kind of doctor should I see if I suspect I have, it says HEDS, cannot talk, little tongue tug.
So the diagnosis can be made by a geneticist. I think usually we make the diagnosis by genetics, but there are rheumatologists who have expertise in this field, and some physiatrists are actually very familiar with Ehlers Danlos syndrome as well. I have patients who were referred to me by physical therapists who have been very tuned into this possible diagnosis and are able to recognize it.
Okay. Mast cell activation disorder, what is that? Loaded question. Yeah.
The mast cells are cells in the blood. They're part of the immune system, and they really form our first response. I've heard Dr. Ann Maitland talk about them as our first responders. And mast cell activation happens when the first responders respond, but then they don't know how to stand down. So the cells have many, many different inflammatory molecules inside of them, and when they release these inflammatory molecules, they cause all kinds of havoc in multiple different organ systems, literally from the brain right down to the pelvic organs. And that inflammation causes lots of different kinds of symptoms.
And the last question, does taking collagen help EDS?
So this is a very interesting question, and one that I've been thinking about lately, because I had a patient who came to me just last week who was advised by her rheumatologist to eat a diet very, very high in college, and she was advised to make bone broth, make stews with bones, and she had been diligent, I mean the ultimate compliant patient for almost a year, and she told me that her joint hypermobility had improved as a result of adhering to this diet. So I have been poo-pooing the idea that eating collagen is going to help at all, but now I'm kind of trying to open my mind and think that maybe it is something that we should study.
Thank you. Thank you so much, Dr. Francomano, for your discussion
Thank
today.
you very much.
Appreciate you being here.